Now it's the time for the first panel discussion of the day. And this topic is on Health 4.0, a vision for smart and connected healthcare. As usual, we have a very eminent set of panelists, and it's my pleasure to call them on stage to join us for this panel. Can we have Commander Navneet Bali, CEO of ClearMedi HealthCare, Professor O.P. Kharbanda, Pro Vice Chancellor Health, MS Ramaiah University of Applied Sciences, Manisha Kumar, Regional CEO, HCG Hospitals, Dr. Chandrasekar Chikkamuniyappa, CEO of DHEE Hospitals, Dr. Parameshwara CM, founder and CEO, Smiles Institute of Gastroenterology and Hospital, Joseph Pasagha, Group Chief Operating Officer, Sparsh Hospital, and Govindaya Yathish, Unit Head, Apollo Hospitals. Thank you. So, since it's quite a big panel, one request to each panelist to be succinct and crisp with your answers so that we can discuss more. So what I would like to start, and this I would come to each panelist with this. So when we are talking about Health 4.0, smart connected healthcare and all these things, I'd like to start from the very basics, very fundamental. What is your concept of smart healthcare? In today's scenario, what does smart healthcare mean? And what are the principal benefits? Not just theoretically what smart healthcare means, that doesn't benefit anyone. But for the patient, ultimately any aim of any healthcare process is a benefit of the patient. So from a smart healthcare, how would you sum up the measurable benefits that a patient can get out of this smart and connected healthcare system? So this is a question I would like to put to all the panelists, and I would like to start with you, Commander Navneet Bali. And maybe I'll ask each of you to take 2 minutes on this, and then we'll take up the next thing.
Good morning, and starting my stopwatch.
Sure.
2 minutes. I want to be smart, ask a smart question. So thank you very much for inviting me here. You asked me about smart healthcare. I think the smartest healthcare would be when there are no patients in the hospital at all, and everyone is healthy.
That's
and you sit in your homes, and hospitals don't either exist or exist for very few people. That is the smartest healthcare. But since that is not possible, it's an utopian idea. The next thing, if you ask about smart healthcare, I think if the patient goes to a doctor and what he or she is supposed to undergo, either a procedure, an OPD, or a surgical procedure, I mean, that's exactly what the patient is actually spending his or her time on, and everything which happens around and across it is a waste of time, and it is taken care in such a way that the patient and the attendants don't have to hit their head against whatever they go through. So that is one part of the smart healthcare. I usually compare healthcare with the aviation industry and how it has evolved. So if you look at a pilot who's sitting inside the cockpit to be a surgeon inside an OT, when you today have to go to an airport, you booked your tickets online, everything is online, your baggage is taken care, you just go and sit in the aircraft, and the pilot flies you to place A and place B. And that is what smart aviation is about, which was not there about 10 years back. You look at, get out of Bangalore, Delhi, NCR, and these big cities, go into villages and towns and cities. And even in cities like Bangalore, etc., in Delhi, you still find thousands of patients in the OPD standing in the lines. You still find people getting discharged in 8 to 10 hours. You still find people not getting their reports. You still find difficulty in getting appointments. Today, let us see everyone sitting in the room has to just go and meet a doctor in any hospital in Bangalore. They'll first see if the doctor is good or bad. Is that facility nice? How will they get an appointment? Do you know somebody in that hospital whom you can talk to? And then you can go there and you tell that person, I'm coming in so-and-so time. And when you reach that hospital, you might find the doctor is not there, or you take hell of a lot of time. The billing is not sure, you're not sure how much you're paying. So, we are today, if you ask me, a very, very inefficient industry, despite the fact that we talk a lot about AI, we talk a lot about digitalization. But, the dream of mine would be when all these paraphernalia which a patient has to undergo, except when he or she is actually undergoing a procedure or an OPD, everything vanishes and you have a patient. The other part of the smart story would be actually what the doctor or the clinician is doing. That is about having better surgical systems, better medicines, all those innovations which happen typically in the medical part of the journey. So I will just stop here. Thank you.
Thanks for that analogy with the aviation industry. And as you rightly mentioned, yes, and I hope that dream is not utopian, where smart healthcare means, as you were saying, that all those paraphernalia are not felt by the patient or the caregiver, either of them, and the focus is purely on the quality of the care. Great. Dr. Uma Nambiar, the same question to you. What are your opinion?
By the time you reach the end, all things would have been answered. Yeah. So just in one line, I should say that, if I was to look at what do we really require from healthcare delivery and what do you require as a patient is, and in the entire ecosystem, you can never get rid of illnesses completely. So we should know that patients should go to the hospitals for acute care events and all the non-acute care events. They should try and see whether we can provide them at remote locations or wherever they are, even when they are traveling and we are so mobile. So it should not come as a stress point. It should not impact on any other thing. And while we are doing it, obviously, when you use the word smart, it means you're using certain technologies to achieve that smartness in the existing healthcare system. So the smart used in a manner that the points of stress in healthcare ecosystem are cost, access, and quality. That should be addressed without anyone feeling the burden of it. And for the doctor, there should also be no stress. There should be efficiency and improved outcomes, and also a continued learning process so that they are also up to date in technology.
Thanks. So very critical point, reducing cost, access, and improving the quality, not reducing access, reducing cost and improving the access and quality. And these are the issues maybe in the next round we'll take up in more detail. Now, next I'll come to Dr. Sanjeev Kumar, your views.
Thank you. So basically, smart healthcare, since I work in a place which is away from Bangalore, we are 70 kilometers away. Let's imagine that a remote part of our country, or Karnataka, a patient is identified who is in the high-risk category, has a wearable device. His device emits out saying that, there is a ECG which is not right. He is identified and there is a command center which says, okay, this fellow is in trouble. And the ambulance reaches there. The ambulance is equipped with all the IoT devices, so the monitors are all connected, and whatever needs to be the first aid given there, and from there the patient moves to a tertiary care center where the treatment is given. So this, I would say, a smart healthcare system at a tertiary care level. If you go towards a primary care or a preventive care level, see, our country, I think nutrition is one of the big things at this point of time. I see a lot of construction workers. Most of them are all having a smaller stature, whereas those who have good nutrition, they are well built. So that means there is a deficiency, whether it is protein deficiency or whatever. They are identified. See, three things are important. We have the infrastructure. There is a lot of infrastructure. We have the manpower. It's just that we need to connect these things. There is technology available. Even the technology is there in bits and pieces. Now, unless they all get connected, once they get connected, I think it will be totally different. I think the government is also working on that. Connecting is the most important part of this. This is what I would say will be really a smart healthcare system.
Okay, so that connecting is one challenge, but the tertiary healthcare example you gave, maybe we'll discuss it. There's the challenge in terms of the uniformity in the quality of healthcare which is being provided, infrastructure in terms of everything from bandwidth to everything. Again, that is not standardized in such a diverse country. And then the costs. Yes, so we will take up that discussion in more detail. I'll come to you, Professor Kharbanda, next with your views on this.
Thank you for inviting me here. I have 3 points to make. The first point is that definition of smart healthcare keeps changing. What was yesterday smart, today is obsolete. And what is today smart may not be smart next few years, maybe 3 years or 5 years. So that is one. The second thing I wish to add here is that perhaps we need a system which is perhaps on the card by the government, that each individual, like we have an Aadhaar card, we should have a unique ID health card. It could be linked to Aadhaar card also. And this is the card, this is the chip, or this is the cloud, whatsoever you may think it, has your data from prenatal, from conception till you are from womb to the tomb. And once you have this information, say about 1 million people, a lot of logistics will come out. How we are working, how we are taking. I'm looking at a very broader aspect of it. And the third thing I wish to add here is that a time will come and everything will be remote. So doctor is remote, nurse is remote, everything is remote. But now, what happens to the psychological and mental health of that person who has not met the doctor? So, I think we'll have to create virtual doctors. And virtual doctor doesn't mean only an image. The one who feels like mother, the touch of the mother, the feel of the mother, the feel of the doctor. So, these are the future challenges I am putting it forward. These are just my thoughts, but if we could think that we could land on moon, we can also think of all those aspects.
Okay.
Maybe another 5 years or 10 years.
So your definition of smart is moving. Yes, it's a relative term, but some of the ideas might be a little too futuristic, if I may say, because there are a lot of even this womb to the tomb thing that you mentioning. While the remote part, some bit we saw during the pandemic, but how is it possible to address all the infrastructure and connecting them together? Maybe that will be a big challenge in today's scenario. Okay, Manisha, Kumar, I'll come to you next with your views on this.
Yeah, thank you. I think most of the points on what smart health really encompasses are covered by the panelists. Maybe I'll talk a little bit about how we in hospitals are trying to implement it. If I talk about the outpatient ecosystem, today most of the providers, at least in the private space, are already doing it or moving towards creating a digital front door, which essentially is, one touch point for patients through which they can avail all the services of the outpatient ecosystem, right from appointment booking to seeing a doctor, telemedicine, sample collection, e-pharmacy, and what have you. So that this cuts out the need for them to frequently visit hospitals. So it creates convenience, it subsidizes costs, and all the points that we discussed. Likewise, in the inpatient side, of course, most of us today have EMRs or EHRs. And the next level to that, and somebody rightly spoke about connectedness, what is important is how well the patient records are integrated with all the devices in the hospital ecosystem so that they can be used real time by doctors and practitioners to take informed decisions to diagnose and treat. And I think the next step forward, which we are all aiming to do, there are a lot of software companies, organizations that are working in this space, government is looking at it also, is to really create interoperability in the entire scheme of things for patients so that when they move from hospital to hospital, city to city, in a different network environment and so on, they should be able to use the patient data, which is owned by them, as well as various providers and practitioners across should be able to use the patient data to carry forward the treatment. That really is the next step.
Okay. So the focus on integration and interoperability, yes, but this data, there are a lot of regulatory challenges and confidentiality things might come up in terms of reusing that data. But yes, it's a valid suggestion. Next, Dr. Chandrasekar from DHEE Hospitals, your views.
Yeah, I would like to take it in two bits because I am an orthopedic surgeon and a joint replacement surgeon in particular. I'll go more close to the patient. So these two sets of patients is one patient who is already having severe knee pain who comes to the hospital. Another patient is around 30s who is having knee pain. Now for the first set of patients who has severe arthritis, needs joint replacement, comes to the doctor, comes to the hospital. So we are in a smart hub, and before the patient comes to see me, I have the whole data on the patient. Okay, so my AI and predictive, generative solutions have given me all the data about the patient, including the radiological, medical conditions and everything, along with the psychosocial, patterns of the patient. Yeah, so we tell our juniors, if the patient is crying, be very, very careful before deciding on surgery, because it may not be the pain which is making her cry, it may be something else. So this is very important. So once that step is over, so I have a, leisurely conversation with the patient, and once it is done, she goes to the next room where she is educated about the surgery with all smart tools and AI generated models and surgeries. She can see, she can ask questions. Everything is made very easy with all the tools available today. So we plan the surgery with a robot, and the robot gives me all the possible complications, possible difficulties during the surgery, and we do surgery with the robot. Patient goes to the ward, and our physio knows what are the muscles, what are the things patient is finding difficult, and he exactly works on that and rehabilitates them. And the patient goes home with the wearable devices, and I don't have to worry whether that patient is suffering from fever, pain, and because everything is monitored from the hospital, from our team. So what is going on with the patient? So I don't have, now it is disconnected healthcare. So once patient is discharged, I don't know what is happening with the patient. And the next time I see her in 2 weeks' time, when the patient, I see them, it may be infected, it may be some other complication, DVT. So now it's not there because my wearable device and the other tools go with the patient, and we keep connected. So patient comes back happy, and then outcome is great. This is one set of patients, our smart healthcare hub. And the next set of patient I spoke about is a 30-year-old patient who comes with knee pain, who is worried about the arthritis and future problems with arthritis. And I am able to generate a predictive analytics of this patient, including the genetics, this thing, and tell her in 10 years time, in 20 years time, if you continue this lifestyle, you are going to end up like this, and let's intervene here. Intervention may be just lifestyle, intervention may be genetic, intervention may be whatever newer tool that is available for us. So we prevent a surgery, we prevent that pain, and suffering for the next 20-30 years. So this is what a smart healthcare 4.0 means to me.
Okay, excellent. So in the first instance, you have given an ideal, if I may say, use case about from the consultation to the surgical procedure to the post-operative care. And the second instance is obviously a little bit more on the predictive thing. Great. Next, Dr. Parameshwara, your views on this.
Yeah, thank you. For me, smart healthcare means to be present in every part of human being's journey, from preventive, promotive, and curative healthcare. It's just doesn't mean that when the person is sick, the smart healthcare has to be. Rupinder Singh was mentioning that in the future healthcare is in chips. And Prof was mentioning what is smart today is not smart tomorrow. So as of today, we are in version 4.0 of healthcare, where we are trying to connect all the industry 4.0 versions like AI, predictive analysis using ML, AI, big data, and all this stuff. So in my practice, I'm a colorectal surgeon, and I was never disconnected with any patient. I operate at the other end, and the other end is a very painful end for any person in this world. So that's why the English term pain in the A has come. So when this I was going through this problem of pain, so we worked with the American Indian company based out of US. We developed a conversational AI where the person interact with a platform on his mobile application. So before, every patient used to WhatsApp me and tell this is what is undergoing. Now the patient interacts with the mobile application and the patient pain ends there. Second thing, as Dr. Chandrasekar mentioned, so we also have a wearable device where this visual analog scale, pain scale is there, and we measure the pain, and our conversational AI gives directions to the patient regarding painkillers. So this is what we are practicing in our institute when it comes to pain management and post-operative care.
Okay. So you are giving a little bit more on the glimpse of the future, how conversational AI is being used. Okay. Joseph Pasagha, your views.
Yeah, thanks. So gone are the days when you have large infrastructures, huge edifices and buildings. So what I typically name it as the inverted pyramid. It used to be wards, patient beds, and ICUs as the pinnacle of the pyramid. I foresee healthcare today as the inverted pyramid, where patients will come to you only when they need surgeries or intensive care. Everything else would be provided by, like what Doc said, wearables, devices, remote monitoring. I remember 15 years ago I started telemedicine in Narayana Hridayalaya, and that's the way forward. It's going to be remote care, remote monitoring, and wearables and devices, and that's how the technology amalgamation with healthcare is going to go. What was science fiction yesterday is going to be reality today, and I strongly feel that's where we are headed. And longevity today in the world is growing, and then assisted living is another big space that we need to be. And nobody wants to sacrifice a day. The children are not here, and even if they are here, they don't want to sacrifice a day and then come to the hospital and stand in a queue. It's going to be a queueless hospital. Yeah, it's all going to be assisted and monitored and technology driven, and that's how I foresee. And then I think that's the way forward.
Okay.
Yeah.
Okay. Thank you. So the emphasis was more on the remote monitoring and the remote care. Govinde Yatish, yes, your views.
Yeah, namaste. I think they all spoken. I don't think they left anything to me, but definitely, I would say, being the champion of patient safety, patient advocacy, and all that part, we literally use the tools. If I want to say, what I've recently adopted in the last 1 year and how it make a difference. Today, my hospital in Jayanagar, which is all the beds are continuously monitored. Thing is, that's how we have enhanced the safety net. Thing is, almost I would say yes. I had about 4 instances of code blue, and I know why reasons we had codes on the floor. Thing is, the point I'm making here is we are talking too much about science, technology, data, all that part jargons, but are we applying enough? Is the point I'm making. So thing is, let us be more prompt and proactive using technology and overcome the barriers of what the challenge we are facing is the point I'm making.
Okay. So more proactive adoption. Great. So we have a fairly good idea of what each of the panelists are thinking when we are talking about smart healthcare. And now let's get to some of the more critical points. I'll start with you, Commander Navneet Bali again. When you were mentioning earlier about what you foresee, in a healthcare ecosystem, there are so many stakeholders involved. There will be the doctors, there will be the surgeons, the patients, the nurses, the caregivers. Now, let's assume we have some sort of this smart healthcare ecosystem. But unless each of the, how do you sort of engage each of these stakeholders in the ecosystem so that they are on the same level or same plane? Otherwise, the thing will not work properly. So what are your suggestions there?
See, healthcare continues to be a very emotional subject. When I compared healthcare with aviation and we talked about it in context of many other industries, there's a huge amount of differentiation in how the two work. And then you also have, as I said earlier, hospitals in top-class cities having top-class facilities with top-class doctors. And then you go down to towns and villages in India, we have many, many hospitals across many, many small cities. And the whole thing changes. You don't even have trained nurses. You just have people who are trying to save some lives there. And so the entire thing is different. So when you talk about this connected healthcare or the smart healthcare, right now, if you in India, it's absolutely fragmented. Say some of the doctors here spoke about their own experiences in their hospitals when things are available on the mobile phones, the data is flowing in, they're monitoring. But how many such hospitals in India, are there? Secondly, the adoption of technology at every level, starting from doctors adopting EMR, the other caregivers wanting to adopt technology. Again, it's very, very fragmented and with no fault of anyone else. I remember our journey in NH and when we started with EMR and doctors would want to say that they don't want to type, they don't want to sit in front of the computer, they would rather spend time with the patient, speaking to the patient, touching the patient, understanding the patient, or whatever it needed be. So, right now, I have no such solution to offer to you. But yes, there are many, many solutions being proposed by silos, by startups, by hospitals wanting to take up. There are a huge number of apps. There are many, many different HISs which hospitals have. There are different type of EMRs which are going on all around. So again, you compare this with any mature industry. So when I spoke about that we are a highly inefficient system in healthcare, we have a long way to go when we are at that level when all these things happen as a matter of fact. You don't have to, everyone is trained, everyone is on the same system, everyone is adopting technology, the patients understand it, the attendants understand it, the professionals understand it, they adopt it. And also one more thing, we talk about regulated healthcare and we are very wary of too much government regulation and we talk about it. But you look at the industries which have matured, you don't, when you go and sit in an aircraft, again, taking back the aviation analogy, you're very sure that the pilot is 100% trained and they follow a set of rules and how the aircraft functions is very, very clear how the functions. We are nowhere near that in healthcare today, for whatever you call it. So I think we cannot discount the value of policy making by the government. We cannot discount the fact that technology has to seep into every one single healthcare worker, starting from maybe the housekeeping staff to security up to the doctors. We cannot discount the fact that all attendants and patients themselves have to be also on that plane. And that is the journey I think we have just started and there's a long way to go. Thank you.
Okay. Thanks. So maybe, yes, that ideal situation is still quite far off. And one other thing you mentioned about the policy, yes, the policy framing is important, but perhaps even more critical is application of that policy. Otherwise, nothing will move. So, Dr. Uma, what I will come to you is, one, there are different type of patients also. From different economic strata, different age groups, different cultural strata, everything. And in a vast country, that will be true. And we know a significant part of the care is more psychological. So when we talk about all these technology deployment, smart healthcare things, how is that, if some sort of standardization is possible in delivering that care, How do a hospital achieve that?
So we all know that there is a change in the way we are thinking of the healthcare and the way delivery is changing with the use of digital technologies. You mentioned about patients and the different stakeholders who are involved in this. The term which was introduced by the speaker in the previous section of interoperability is a very important word to understand how there can be uniformity and standardization of healthcare delivery across all classes and masses. So whatever be the strata of population, everybody will be given the same healthcare. Now when this ecosystem is changing in the manner in which it delivers healthcare, we have to start looking at the participants of the healthcare system slightly differently. We must understand that entire healthcare delivery and management is smart data management. It has always been data management. Healthcare is nothing but managing data of the patient by the doctors and the other care providers. Now we have different tools to do that. The moment your tools are different, we need to start understanding that there is a data creator or the patient where the data is generated. There is a data collector, which is a healthcare delivery provider. There is a data manager, which can be anyone in your IT team. There are people who analyze that data, who are the data analytics specialists in the healthcare system. And there are consumers of this data, which would be, again, either the healthcare delivery providers or the consumers. One had to start looking at it differently and understand that if we need to manage data smartly to create this ecosystem of equal opportunity to everybody and equal care to everybody, then we need to start thinking differently and work standardizing in the system.
Okay, that's a innovative way of explanation that you gave each of the stakeholders around the data and how it was done more in a corporate manner, if I may say, but yes, for a smoother.
I'm now part of the government healthcare system and it's the same thing. It's the same thing. It doesn't change.
Great. Okay, Dr. Sanjeev, I'll come to you next with one area we heard in the morning session also about, especially under ABDM, a lot of these data and the criticality of data in terms of data being collected. What about still the technology infrastructure that is supporting that data? Even the COVID thing, we saw at that time there were no other means. But what most of us have realized, even getting those vaccine appointments and the way the data was in a lot of cases being compromised, data was crashing. So are we ready when we are talking about all this smart healthcare and we are realizing the importance of data? But do we have the infrastructure really which is able to support in a population of this magnitude, that's infrastructure?
I always felt healthcare is one of the most complicated industries. What happens is, like any other service industry or a manufacturing industry, there is a set protocols which are always there. That this is for if there is a manufacturing of certain thing, stage 1, stage 2, stage 3, and you have the end product. So there is very clearly defined process and protocols. Now in the hospital, as it's medical science is not just science, it's an art. So there is a lot of human intervention involved. That is one part of it. So how do we overcome that? Basically, like how the clinicians derive clinical pathways, there has to be a certain SOPs, which of course many hospitals which undergo accreditation, they do that. But again, I come back to the same point of connecting everything and deriving a standard protocol. I think the infrastructure wise, we have. See, what are the things we are talking about 4.0, smart healthcare and all. So what are the things? One typically is the data which generates from the wearable devices or the devices which are used, like Dr. Chandrasekar was saying, we have systems where you can give a patch to the patient and that data is monitored. there is already an infrastructure there. It is only which comes into the same structure that is very, very important. See, there are HMISs across all hospitals. Whether those HMISs can talk to each other. There is a protocol, let's say sir says TKR. There is a TKR, there is a process protocol. There is a clinical pathway driven. Whether we can follow that, the robot has the same inbuilt system where the AI is built in, and every TKR surgeon does in the same methodology. So I believe there is an infrastructure already there. It is going to be challenging, but at the same time, we have to adapt. Healthcare is always been at the back end of adapting technology. I think we have really not gone there and adapted technology to the fullest possible extent. That connecting is become very important. That's my gut feel. I mean, that's what I feel is very, very important. You have to connect.
Okay, that connection is critical. Okay, Professor Kharbanda, next to you, and since you are representing from an academic institution also, a slightly different question for you. We are talking about a lot of these infrastructure. These all require people coming with specific skill sets or acquiring newer skill sets. So are the academic institutions really providing doctors of the future or even other healthcare professionals who are really getting equipped with these sort of skill sets?
I think this question is very relevant with the way we are expanding our number of institutions which are coming up. Government is encouraging new medical colleges. Like in UP, they said that every district will have
You're not audible to the...
Every district will have a medical college. Now, it is too fast. Too fast. Too fast. That is one thing. The second thing is that this technology requires investment.
True.
And three, most of us, we like to follow the guidelines of the council or the regulatory body. If regulatory body does not insist that a nurse should be trained for this kind of an hospital information system, why somebody would train them? So this thinking will have to change from the point of view of from the regulatory body itself, that our modern hospitals or our modern, even for NABH, if they give accreditation, if they are thinking of modern technology, that should be integrated. So what we do most in our country is by regulation, not by passion.
Okay.
So I think that is a challenge, and that will require a lot of thought process and change in mindset, not only at from the top level. I think bottom-down approach will also be needed.
Okay.
Bottom-up approach.
So the whole dynamics of policy framing need to get altered, if I may.
Yeah, it has to come in.
Yes, exactly. Exactly.
Uniformly and across.
Okay, thank you. Manisha, Kumar, I'll come to you next. One panelist emphasized on remote monitoring and remote during the COVID times, we had increasingly seen it was at the same time this teleconsultation, even the regulations, the law also got passed around that time only. I think it was in March 2020 when the thing was starting. Yes. Having said that, there was an increase obviously in teleconsultation. That was out of necessity. But as things normalized, most hospitals still hardly there is any sort of teleconsultation happening again. So God forbid there is no such pandemic again. But keeping in mind situation, will teleconsultation or remote health monitoring will remain only a feature in case of pandemics, or what are preventing that becoming mainstream for hospitals? So it's just a psychological mindset or something else?
Yeah. Of course, during COVID time, there was a sudden surge in the adoption of telehealth and need-based, right? Because there was no other option. And after that, while it is tapered down, there is still a big use case for it. and it still exists in hospitals. So I'll tell you two scenarios, how we used it then and how we continue to sort of use it now. So within hospitals, when we were stretched for capacity during COVID time, we used step-down ICUs. We used remote monitoring within the hospitals so that we could expand beds without really adding people and with limited infrastructure, because we wanted to take in, there was huge deluge of patients just to manage that. And today it is sustained. So our hospitals, like 23 hospitals across India, we have tele-ICUs set up. We use cloud physician. We have step-down ICUs. We continue to do home monitoring, and it's not just us in HCG. I know most of the big corporate hospitals have been with Max, Manipal. Everybody has a huge focus on home care for palliative, post-surgical, supportive care, which is using remote monitoring devices and using technology and staying connected with patients. So if we, like for like, yes, not as many volumes as that happened in COVID. If you see virtual consultation alone, yes, if you have the option of, and I think, in the beginning he said rightly, it is such an emotional subject that if you have the option of seeing the doctor face to face, you can actually make it to the doctor's clinic. You wouldn't, not just India, anywhere in the world. It's easier to get appointments in India. If you go outside, you'll have to wait for months to see a doctor, right? So if you have the option of seeing doctor face to face, you would much rather avail it. But we do virtual consultations for patients across India. A lot of international patients consult with us virtually. So while in terms of adoption volumes, it's come down, but we are continuing to use this technology, and most of the hospitals are, and there's a lot of acceptance now. There was tremendous apprehension before, whether patients will be comfortable, whether clinicians will be comfortable, how the patient satisfaction would be. In the beginning, there was a point of discussion, how do you measure if you are being successful with technology? And the real measure is, aside from the clinical outcome, which is a longer haul measure, is how the patient and practitioner both feel satisfied. And if they're both satisfied and there is no compromise on communication, then it is a win-win, and that is real immediate measure of success.
Okay.
So I think from that point of view, it stays and it will find more use cases and will grow.
Okay, thanks. So a very positive feedback on how the tele-consultation or telehealth monitoring is happening. Maybe with one of the panelists, I'll take it up slightly later, more briefly. Next, Dr. Chandrasekar, and I will, you gave that instance earlier. Very nice and ideal implementation, but all those infrastructure comes at a cost. And no hospital is a pure philanthropic organization that, so a lot of that cost will go to the patient. There will be passed on. So, and again, we have patients coming from so many socioeconomic backgrounds. So how do you manage the costs and budget?
Yeah, this is a great question. Actually, I wanted to suggest that so much of technology and so many people and all the tech startups which are coming into healthcare, and they are looking at a lot of profits. So when you are looking at a lot of profit, that means it is not accessible and affordable to everybody. So, personally, from the last 12 years, we have been working on, bringing clinical intelligence. And 12 years back, we started the journey. We have burnt 20 million rupees on creating a software, and we are not yet successful. And now we are piloting a remote monitoring system. So it is very, very expensive. So making it available for everybody in the country and every hospital is going to be an impossible task if it remains a commercial event. So I was very happy looking at ABDM's plans, and I was thinking that if government can take up this and then make the cloud services or the healthcare analytics, accessibility of EHRs for every hospital and every patient everywhere, and that is that is how it is going to be accessible to everybody. That is the only way.
But is it practicable
No,
for
that's
such
what
a...
I'm saying. I am talking about how to make it practicable. Okay, so it's not practicable in the present scenario. If
True.
A commercial aspects of the healthcare delivery system, the way they are now continue, it is not practicable. Yeah. So, but if we have a public-private partnership, if we have philanthropic organizations coming into this and then supporting the technology. See, 50 years back, you know, a 2 million warhead will go and fight the war. And today a $200 drone will go and destroy that. So I'm sure that technology will come up and will become cheaper also. It's not that all the technology which is going to come is going to be expensive, but I'm sure that the technology in the future, now, you know, your mobile, you are there with every patient. Yeah, and I'm sure that the wearables are going to be more and more cheaper as we go and more people adopt. And doctors adopting to technology is another big solution. I'm sure all the administrators here will agree that putting the data into the electronic system is still a challenge across the globe, not just in India. Okay, I worked in in the West, in England and in America also, and there also it is the same challenges. The technology adaptation by the doctors and the nurses is a challenge everywhere. So there are challenges everywhere, but I am sure that it will be possible in the future, or it will be inevitable in the future for this technology to be made affordable and accessible to everybody in the country.
Okay, great. Thank you. Dr. Parameshwara, would like to, I think you are one of the panelists also mentioned earlier about the predictive nature of diseases. So, and that is more important. It's an old adage anyway, that prevention is better than cure. So, how effectively do you see this predictive analytics of diseases can become mainstream? Because again, not very isolated cases, unless they are not scaled up, nothing beneficial will really happen. So where do you see that scaling up happening in terms of more predictive analysis of diseases and accordingly actions, prescriptive actions being taken?
You are right. Actually, the smart healthcare is really smart when you predict a particular disease.
True.
And prevent it. Okay. So in one case, what I would like to give an example is being a colorectal surgeon, the gut microbiota analysis. You know, the gut microbiota analysis, what we're doing in the recent times, will predict the nature of the disease the patient is going to have. It may be cancer, or rheumatoid arthritis, or cardiac diseases, and all this stuff. So this is one thing. The second thing is by gathering big data, by gathering huge amount of data, and by putting the data into the machines, these machines will give the proper nature of the disease which is predicted by a particular human being. And these machines have to be updated, refined on a timely basis, so that it is updated as the disease patterns progress. So predictive analysis is going to be the way forward in healthcare.
Okay, so the predictive analysis is going to be, as you mentioned rightly, the game changer. Okay, Joseph Pasagha, I'll come to you next with the earlier question. One of the panelists I asked about the remote healthcare. Again, in remote healthcare, where we talked about the psychological aspect, but infrastructure is also still remains another critical issue for the success of remote healthcare. And again, it's not, the infrastructure is not standardized, maybe beyond the metros. So how do you ensure that happening?
Yeah, could be beyond the metros, could be in the metros. So at Sparsh we launched about 6 community clinics. It's not about a nurse or a doctor being physically present. So I put up some ECG machines in these community centers, and these ECG machines, they read the patient's heart, and the thing is beamed straight to the cardiologist's mobile. So that's as seamless as it can get, remote monitoring. And he assesses the wave patterns and says, do you need to come to the hospital? No, not hospital. Do you need to take some blood thinners at your place? And then he does that. So I say we are about decades away from the other industries. I leave my car to the garage, and then I get WhatsApp instantaneously. Your bonnet is opened, the engine is opened, your thing. So it's as predictive as that can get in healthcare. If we could do that seamlessly with technology, it's adoption, as Doc said. If our doctors and healthcare industries can adopt technologies, it's all there. It's all over, all there. It's just that we refuse to believe that we are not there. Yeah. So we, as Commander Bali said, we are still the most unorganized industry among industries. Yeah, that's my 2 cents on that.
Okay. Thank you. Govande Yatish, my question is on to the extent these different types of digital tools, again, that has to be done in a phased manner. Maybe, say, robotic surgery, if I take one area, you can have some procedures use robotics. You suddenly cannot today, for all different reasons, have start every surgery done through robotics. So, and other digital tools also. So how do you suggest these phasing in of these different technologies, digital tools in a hospital?
Yeah, precisely, like, what's your priority? And based on priority and how quickly I can adopt it. So these are the 2 things matters a lot. Thing is, and then next is, how much are you, your appetite is there to invest on the technology. Today, all of us are sitting that with the robots in all of our hospitals. But thing is, what is this capacity utilization? Thing is, that is a review when people ask, none of us got an answer. Thing is, the ROI to a robotics technology, because of the invention, the investment went behind that. It is not viable. Yes, it's a tool. It is required, but it's also evolving. We need to know that. We need to be there, so that when the futuristic curve or we need to catch at the early phase, and we need to refine ourselves and be ahead in the curve is one of the part all of us take. But when it comes to buying the technology and adopting, I would say it is the will of the champion who want to drive it. There are some experts who do end-to-end cardiac surgeries without anything, but at the same time they sacrifice themselves in focusing only on cardiothoracic surgery of doing a CABG or a mitral valve and all that part. But at the same time there are people getting I do only robotic, I don't want to do robotic joint replacement, I don't want to do a conventional surgery. But there are other people if I do a regular conventional robotic TKR to my skill set of being working for 40 years, it's the same. Thing is, if I do in 25 minutes one knee, if I do in robotic it takes me 1.5 hours, why do I need to waste my time? See, thing is, we are all in the phase of adoption. Thing is, each and everyone's story is different. But thing is, the lessons need to be learned from each story, and the champion is the one who acquires and has got a large set of data to validate the outcomes and to say to the world this is better than this, that's better than that. See, ultimately we are following the evidence-based medicine. Which one is helpful? Today, see, Johnson & Johnson I'm taking the company's name, they came a bit later into, they are the leaders in the joint replacement at some point of time. Now everyone caught up, right? So, but the data what is coming across says whether it's a robotic TKR or a conventional TKR, the outcome remains same. But as it evolves, the data comes from all the companies and everyone, when they put across their data, the whole thing will going to change. Thing is, but are we there? Is the point. So ultimately what I want to summarize is, yes, the one who adopts it and once who uses it with, for the purpose both improving the outcomes, improving the efficiency, improving the satisfaction, will be there for a longer time. Yes, scaling up will definitely happen with technology, but at the same time, like, equitable distribution is also, like, one part of the thought process. And one more point I want to summarize it because I don't know whether I get the chance or not. The standardization of wearables, monitoring, the care delivery process will definitely get standardized, whether it is a government setup or a public setup or a tertiary care or a corporate setup. Thing is, the care delivery will definitely going to become standardized, protocol driven, and everyone will be accountable. At the same time, like, the NHA, what we are, I think a couple of officials are here might have spoken. Thing is, it's a beautiful tool, like, the entire highway of data, migrating data from patient to caregiver to devices to everything to payer to the whole thought process is really great. Thing is, we're definitely going to have very great tomorrow, like, Dr. Chandrasekar will operate from being in Goa, and, like, his patients will be monitored and seeing, like, yes,
Great.
doc, I'm very happy. So that's, it's not going, it's not a fiction, it's in the reality.
So those best practices are still emerging and the standardization. Okay, you'll get a chance. We'll start with you the last round and just 30 seconds to each of you. Maybe in your hospital, one best practice or initiative that you are going to undertake related to over the next 1 year, 1.5 years, starting with you.
See, what we have done is the electronic medical records, bits and pieces we are implementing. Like, now we want to take it up, like, integration of the machine inputs to my electronic records and completing the whole process of continuous monitoring patient care in the organization is what I would like to take.
Okay. So integration of machine inputs with the EMR. Okay, great. Joseph Pasagha.
So I've been speaking to my chairman, Dr. Sharon Patel in Sparsh Hospitals. If we can remunerate hospital doctors based on outcomes, I think that's going to be the future. Yeah,
Okay.
based on outcomes, remuneration is something that initiative that I've been thinking about.
Okay.
And the other thing is about preventive healthcare, like the one in Kaiser Permanente in the US. And if we can do that and it can encompass that is something that I've been reminiscing about. Yeah.
Okay. Dr. Parameshwar.
Yeah. We are exclusive colorectal hospital. The only cancer in India which is diagnosed late is colorectal cancer. About 78% are diagnosed in the late stage. And we'll be starting the first colorectal hospital on wheels, which will go to every remote corner of this Karnataka state, probably later the whole country. So this is what in the next 1 year we have in the pipeline. And we have done this before COVID. We reached out to 21 lakh families in the Mandya, Mysore, Chamarajanagar region. And we have got the best awareness award from the Niti Aayog. So we stopped during COVID and now we'll start on wheels. So this is the plan in the next 1 year.
Great. Dr. Chandrasekar.
Okay, so for the next 1 year, what we would like to do and we want to do is the continuum of care from hospital to back home and back to hospital. So someone who comes to hospital gets a procedure done or gets treatment given and goes home and he has to be monitored. So it should not end that, okay, till the hospital, you are in the hospital and everything is okay, and once you go there and you end up in complications. So we would like to implement continuum of care, both using technology and offline visits to the patient's home, in the next 1 year.
Thank you. Manisha Kumar. Yes.
So a lot of things we are doing, but I think in terms of predictive medicine and using data analytics for prediction, there's a lot of disruption in oncology. Something that we have done as part of research, but are now taking more and more on therapeutic side also, is radiomics. So radiomics is this field in imaging, which basically uses a lot of quantitative features from all imaging scans, be it CT, MRI, PET scan, and it looks at extraction and analysis of data. So there's few features and few parameters which are available, which are visible with the human eye, but there is so many hundreds of them which are scanned by the equipment, and then using computational algorithm and some machine learning software, using radiomics, we are able to extract, analyze these for prediction of a lot of tumor characteristics. So not just how the tumor will respond to the treatment, but also what will be the odds of recurrence happening, in how much time period can we expect a recurrence, will there be a toxicity to the drug being given, and so on. So this we have done as retrospective research studies in the last couple of years, and we are now doing it therapeutically for patients. So this is one step towards personalized medication.
Okay, so a mainstream of more therapeutic oncology using radionics. That's very interesting. In fact, really interesting. Maybe we can take it up separately. Professor Kharbanda, yeah, your views.
I have two thoughts. One is that I like to convert my nurses into smart nurses to use smart devices. That is where the focus should be, actually. That is where we mismatch sometimes. And the second focus could be, or probably we should work on it, is that introduce a curriculum where how the DICOM data and the clinical data can be tagged. And I think this will have to be introduced maybe at the entry level or at the when the graduates are passing out. Maybe at passing out, that may be a better option. So this would have to be thoughtfully created, a module, and implemented.
Okay, thank you. Dr. Sanjeev.
So what we have done already is we use a patch which basically monitors all the vitals. The patient is given a patch at the time of admission, and even after discharge, once they are discharged for the next 5 days, they are monitored remotely. That patch basically needs only internet connection and nothing else. Your vitals are all monitored. So that is one thing which already we have adapted. Of course, it costs around 1,000 rupees per day for the patient. That is something we would like to see how that can be brought down. Second thing is we have adapted villages. Around 6 villages we adapted. When you say we adapted, we identified the chronic, patient with chronic ailments, whether it is diabetes or hypertension, those kind of ailments, and they are given free medicines also, which is from our side. So basically, how do we integrate technology so that they are monitored continuously, and then if there is anything that can be predicted, if there something goes wrong, some kind of a wearable device which can predict if there is anything going wrong. That is something that we would like to, in the future that we would like to adapt.
Sure, thanks. Dr. Uma.
Hi, so some of you may know, and for the others who don't, I'm from the Indian Institute of Science, so our hospital is going to come up next year. And the hospital is, as part of our infrastructure, digital is our infrastructure, it is not a service. So therefore, and because IIC has multiple other departments, we plan to really harness the full threshold and full potential of all technologies, not just digital, include the research along with our multi-omics departments and the precision medicine lab and the AI lab, including the projects that we are planning to do on digital twins, and to really make a smart hospital which can cater to these needs.
Okay, best wishes for that. Yes, you are the last word. Sure, Commander.
Yeah, thank you. I hope I get 30 seconds more, being the last.
Sure.
Thank you. So, I usually take this opportunity during these conferences to pass this message across. So I'll slightly divert from your question that we are 140 crores, too many of us to look at healthcare the way we are looking at it today. We need to become a much healthier nation, and that's the only way for us to go. Universal healthcare is not going to be the answer for India. So everyone sitting in this hall today, to themselves and to the message to be passed to their relatives and friends, is to become a more healthier lifestyle. Having said that, there are two things that as a company which is looking into oncology as a very, very important focus, and we go into tier 2, tier 3 cities. We have hospitals in villages today who, on couch patients are almost like 250 per day. So there are two things we are looking at. One is we want to bring the cost of CAR T-cell therapy down to around 15 to 20 lakhs from 1 crore, which is today. It's going to happen next 2.5 years in one of our hospitals in a remote place near Baroda. And we also started a concept of integrated health officers, or the IHOs. These are senior nurses who take care of the community, all people who have not come to the hospital. So before they come to the hospital, so general community health, and after a patient gets discharged, then they touch base with them, and we found them to be an outstanding way of looking at the community and looking at the health of the community. Thank you
That's
so
a
much.
very interesting way, the IHOs that you mentioned. Great. In that light, we'll close this panel discussion. And before we disperse, may I request Sanghamitra Mohanty, co-founder of APAC News Network, to just come and present the Excellence in Healthcare Award to all our eminent panelists. Starting with Commander Navneet Bali. Dr. Uma Nambiar. Dr. Sanjeev Kumar. Professor O.P. Kharbanda. Manisha Kumar, group photographer. Dr. Parameshwara. Joseph Pasagha. Govandaya Yatish. So if you could just